What's up, everyone? I'm here with Dr. Steve Haywood, and we're going to be talking about End-Tidal CO2. What is up, Steve?
Hey, what's up, Andy? How's it going, man?
Very good. So listen, End-Tidal CO2 is one of those things that I think we conceptually know that we should be using, but not every hospital has it. And even when people have it, they're not quite sure how to use it. So why don't you take me through, give me a 30,000 foot view of why End-Tidal CO2 is so important for patients in cardiac arrest.
Absolutely. So specifically, waveform End-Tidal CO2 is going to give you so much information about what's going on, not only with the lungs, but also with the heart, with the vascular system. I mean, with the entire cardiopulmonary system can be evaluated utilizing waveform End-Tidal CO2. And in cardiac arrest, it's one of the few tools that we have that we can watch the entire time to evaluate the efficacy of our efforts and the success, or at some point even the failure of our efforts.
Yeah, absolutely. You can do the successes and also the futility for those cases, and we'll get into that. Let me give you a case.
Let's have it.
54-year-old male comes in, cardiac arrest. He's being resuscitated in the field. They put an LMA in. They're coming on in. They're doing chest compressions. They tell you that his End-Tidal is 8 when he winds up in your resuscitation bay. Take me through what you're doing next.
Sure. So we've all been taught that a low End-Tidal CO2 less than 10 equals futility. But the thing to remember is that's after 20 minutes of resuscitation. End-Tidal less than 10 after 20 minutes of resuscitation likely represents futility. They have intubated cadavers, like people that have been dead for a day, right? They intubate these people, they hook them up to End-Tidal CO2, and they give several breaths. And some of the End-Tidal readings were as high as like 60 and 100, and it lasted for almost 2 minutes. They detected CO2. So early in cardiac arrest, there should still be some metabolic activity going on. And so we should be measuring an End-Tidal CO2 greater than 10 or greater than 20. So early in arrest, when I see that End-Tidal CO2 of only 8, something's wrong. We're not doing something right, or there's a specific pathology that is causing that I can hopefully address. And so I want to quickly troubleshoot those things.
Right, and the one thing that people think about with End-Tidal CO2 is it's just a measure of CO2, so it's a measure of the respiratory system, but it actually tells you about cardiac output. If you're moving blood from the right ventricle to the lungs, you get more CO2 out. So the better your cardiac output, the higher your CO2. So tell me now, you give you that information, End-Tidal's 8, you think you have to do something different. What's your next step in resuscitation?
So most commonly, the cause that I see the most often of a low End-Tidal CO2 early in cardiac arrest is inadequate chest compressions. So if I'm not squeezing the heart, blood can't get from the right ventricle to the lungs. Bystander CPR, we start with landmarks. If I don't have any other adjuncts, I start with landmarks. Really, anytime I start with landmarks. I put my 2 fingers, go above the xiphoid, mid-sternum. I press hard, I press fast. Everybody's heart doesn't live there. Some people's hearts, with COPD, it's actually sitting lower because the lungs are hyperinflated, pushing it down. In chronic hypertension for quite some time, with coronary artery disease, a lot of these patients are hypertrophied and are actually shifted to the left side of their chest. And so mid-sternum is not right for everyone. So the first thing I do is I grab my ultrasound while my compressor is compressing, and I look and see where their hands are and see if they're actually squishing the heart with each beat. And if not, I can move their hands, right? I can move their hands to the left. I can move their hands to where the heart is so that we're adequately compressing the heart. And really, before I do that, just the basics, even if you don't have ultrasound, make sure that they're compressing adequately, adequate depth. Especially with bigger patients, we can get exhausted quickly. And so you may just not be pushing down hard enough, maybe pushing too slow or really even too fast. We get that adrenaline burst, but really when we go over rates of 120, we're increasing mortality. Our target rate should be that 100 to 120 beats per minute. So again, to summarize, first thing I do is make sure I have good chest compressions. Make sure the rate is right. Make sure the depth is correct. Make sure my compressor is not just tired and I need to switch out. And then I use my ultrasound to identify where the heart is, and I move my compressor's hands to that spot. And, honestly, if I have a Lucas device, if I have the piston compression device, I can't really move that. So in that case, I'm popping that off and I'm getting my staff to start manual compressions, which is not going to make you a lot of friends, right? Because they love that thing. It saves a lot of backs. But again, if it's not compressing the heart, I've got to have a manual compressor.
Right. So we're looking at if the end-tidal CO2 is low, then you have to do something different. Maybe the heart is not under your hands, so you'll have to use ultrasound, or maybe you'll have to move it around blindly until you see improvement, although that can get a little bit dicey. If you're in a place that uses TEE, then you could use TE to actively look at where you're compressing, but let's face it, not many places have TEE. And then if you see that you think you're in a good position and you're still not getting an increase, then maybe you're not pushing hard enough. Maybe you're not pushing fast enough. And he said, maybe you're going too fast, or, in most cases, you're not allowing enough recoil to happen. Remember, compression is not just about pushing down, it's letting there be recoil, and that recoil pulls in blood into that right side of the heart and allows you to push it down forward on your next compression. So that's great.
Absolutely.
Does it help you? Does that help you out with giving medications with your patients? Low end-tidal CO2, like epi and stuff?
Sure, sure. So, early in arrest, if I've got adequate CO2, I've probably got good vascular tone. If my end-tidal CO2 is in the 40s, early in arrest, I've probably got good vascular tone. I'm probably getting blood to the tissues, getting blood back to the heart. But when that starts to drop, I'm probably, entering that other phase of arrest where I need to tighten up that vascular tone so that I can get more blood. And that's when I think epi has a better role in those situations. I don't know, Haney, you have more experience with that. Well, what are your thoughts?
No, it's an excellent point. Look, when someone's end-tidal CO2 is good and people are like, it's 3 minutes, time for the next epi, I think you have a really good argument to say that this person doesn't need epi. You're doing everything possible. Epi is only there to improve coronary perfusion. And if you're saying your end-tidal CO2 is good, you can make a valid argument that that person doesn't need epi. Save that epinephrine for that situation in the code if you get there, where they'd actually benefit from epinephrine. So I love it. All right, what else do you got
Absolutely.
about end-tidal CO2?
Absolutely. So again, by and large, this is usually going to be poor compressions. And if you're working in a shop where a lot of people are not keen on using end-tidal CO2, I tell you, you find one time where the end-tidal is 8, you move your compressor's hands and it spikes to 40, you'll convert the room right there. So chest compressions, inadequate chest compressions is number one. This patient came in with an LMA from the field. If that LMA is not seated appropriately, if I'm not actually getting the gas into the lungs and out of the lungs, then I'm obviously not going to measure end-tidal CO2. So if they've got a supraglottic device that may be seated poorly, I'm going to listen for a leak. I'm going to, check the belly. Am I just blowing up the belly with each breath? If the patient is intubated with an ET tube, it may be an esophageal intubation. Even if they've been intubated for a few days, things happen. Tubes slip out. And this is really when the importance of the waveform comes in to identify a tracheal intubation versus an esophageal intubation.
Let's take a look at
Because
that.
we can,
Let's
we
take a
can
look.
get CO2
Yeah.
from the stomach.
Okay, let's take
So
a look
this
and
is
see what a
a
tracheal intubation looks like.
Yeah, this is our standard end-tidal CO2 waveform, right? It looks very much rectangular. It goes up steeply, it plateaus, it comes down steeply. You can have some variations of this in normal. Our COPD patients look a little bit more like a shark fin, but you'll have a steep increase and then a steep decrease. With esophageal intubation, if I'm in the stomach, it'll look more like this. It'll look more like a dome, less like a box and more like these little domes, gradually coming up, gradually coming down. And what's important to remember is you're going to get a number with this, and you may get a number of 15, especially if you've got a leaking LMA and you're pushing pulmonary gases down into the stomach and then getting those back out. But it's not going to have that nice rectangular appearance. It's going to look like these little bitty smooth bumps without any sharp angles, without any sharp edges. So if you see these waveforms on your end-tidal CO2, consider esophageal intubation, consider an unseated LMA. If you can hook this to your bag valve mask device, you have to hold a really tight seal through exhalation to measure it, but consider inadequate ventilations as your cause of low end-tidal CO2.
Absolutely. So going back to this waveform, I want people just to understand that when this square waveform is happening, this rapid rise up is CO2 that is leaving the lungs into the detector or into the atmosphere, or I should say into the BVM. And then that sharp drive down is when we're giving a breath. Sometimes we think about kind of reverse, but this is actually what the end-tidal CO2, and this is a normal waveform. Sharp up, plateau across, sharp down. Now, not all your waveforms will look like this. In another episode, we're going to talk about different waveforms and identifying different pathologies. But certainly when you see something like this is worrisome that you don't have a good seal in your endotracheal tube or your LMA, or you're actually in the wrong place in the esophagus, and so you're going to have to reposition things and make things better. Is that right?
Absolutely, absolutely. And like I say, that may be the cause of your arrest. If this is a patient that's been intubated and the ET tube slipped out into the esophagus, I mean, this may be the entire cause of your arrest. So the number is helpful, but you've got to have the waveform with it.
Right. So you're in your arrest, you've been doing this for a while, and you're thinking that this might not end well. You've tried everything, you've looked with ultrasound, you haven't found anything reversible per se. Can you use End-Tidal CO2 to help you determine if it's time to stop?
Yeah, really, if you're doing good compressions, if your tube's in the right spot, and you've been going for 20 minutes. Now, I'm not saying you have to go 20 minutes if you determine futility before that, but if you've been going for 20 minutes and your End-Tidal CO2 is less than 10, and you're circulating blood, well, then at that point, metabolism of the cells is shutting down, and you're not making CO2, and that's really a sign of futility. And if you've been going for 20 minutes and your End-Tidal is less than 10, and you've troubleshot this, and you're getting good compressions, your airway is in a good place, then I think it is very appropriate to terminate efforts at that point.
Yeah. And these aren't things that you're just pulling out of there. These are well-validated studies that show that after 20 minutes, it's safe, reliable, it's convincing that no patient comes back after that. So very, very important to use your End-Tidal CO2 and know the rules. And then I think people feel better in the room when you say that we're going to stop the resuscitative efforts because of this objective data, not just because you feel like you want to stop resuscitation.
Yes. Yeah, agreed.
Very good.
The other thing, early in arrest, if you have a low End-Tidal CO2, especially if they just went down, your End-Tidal CO2 is low, you're getting good chest compressions, you're getting good ventilations. We said that blood not getting to the lungs can cause low End-Tidal CO2. Think about obstructive shock. If something is not letting blood get out of the right ventricle, that's going to cause low End-Tidal CO2, and that's something that we can address. So if they have tamponade, that can present with a low End-Tidal CO2 early in arrest, right? The blood around the heart not allowing to expand. The right ventricle is the wimpy one, so he's the first one that's going to get collapsed. If the patient has a giant pulmonary embolism, if there's a clot there not allowing blood into the lungs, that can present with a low End-Tidal CO2. And then a pneumothorax actually can twist the heart and cause blood to not be able to leave the right ventricle into the lungs. And those are all fixable things, right? If the patient has a tension pneumothorax and they're arresting from it, that's something that I can quickly fix and get return of circulation with that patient, and they can hopefully have a good outcome.
Very good. And on the opposite of that is if you have somebody whose End-Tidal CO2 is very high and they're in arrest, there are some studies that show that you can say that person might have had a dynamic hyperinflation, or maybe they had some sort of hyperinflation of the lung from COPD exacerbation that led to that arrest. So sometimes a helpful an initial End-Tidal CO2 that's very high, even though they're in arrest, can be somewhat helpful. Let me ask you this. Let's say you're working on a patient and then all of a sudden you see a spike up of your End-Tidal CO2 during your resuscitation. What does that tell you?
That tells me that the body something has suddenly drastically improved. And unless my compressor just grew a bunch of muscles, and that's typically a sign that the heart has started squeezing on its own, which perfuses the systemic circulation as well as the pulmonary circulation much better than our hands on top of the chest. So when I see a spike in End-Tidal CO2, I'm doing a pulse check. I'm doing a rhythm check, because that's typically a pretty good sign of ROSC. That's another great way to convert your staff. Once you do this and you're seeing that End-Tidal CO2 of about 15, and all of a sudden it spikes to 40, and you're like, pulse check. It's not time yet. Look at the End-Tidal. Oh, sure enough, we do have a pulse. Sure enough, look at the A-line. We do have a waveform. Sure enough, look at the heart with echo. Sure enough, it's squeezing now. That's going to convert a lot of people really fast to using End-Tidal CO2 in cardiac arrest.
Yeah, absolutely. If I'm running a code on somebody and I see a rapidly increasing End-Tidal CO2, then I'm actually going to continue compressions for 30 seconds a minute later. And this comes from some derivatives of studies that have already been done that say maybe you should just give them a little more circulation before you do your rhythm check. But then you certainly want to check for your rhythm because something has changed there. And the assumption is that you've got restoration of your circulation. So it's a time to check for a pulse, time to look at your rhythm, time to assess the heart. And by the same token, if I'm in an arrest and we're doing compressions and the end-tidal is still staying low, I might still stop and look to see if there's a rhythm, but I probably won't spend a lot of time looking for pulses because again, the end-tidal is low. There's probably not ROSC, but I still do want to pause and check. So I don't want people out there to see if the end-tidal is
Right.
low, skip your rhythm check, skip your pulse check. You want to make sure that there's no shockable rhythm that has arisen during that time.
Absolutely. That's what we're working for, right? We're trying to get the heart healthy enough to hopefully squeeze and have a normal rhythm, but at least give us a shockable rhythm that we can, again, is much easier to fix than a non-moving heart.
Fantastic. Steve, well, that is amazing. A great overview of End-Tidal CO2 and its use in arrest. Why don't we do this again next time where we talk a little bit more about the nuanced uses of people who are not in arrest and how we can use End-Tidal CO2 to help us out.
For sure, man.
All right. Don't forget to like and subscribe to the channel, and we'll see you on the next episode.